All right, Chapter 2, the standards of practice and ethical considerations with pediatrics. Again, a disclaimer statement, I don't own this material under fair use. I'm providing lecture content only for my nursing students using this material. All content within is for educational purposes only. For nursing students, it does not provide medical advice. So the learning objectives in Chapter 2 is identify and describe sources of standards of practice relevant to the day-to-day care of pediatric nurses, identify and elaborate on key themes and the standards of practice, how the Code of Ethics relates to pediatric nursing, pediatric nurses' scope and standards of protocols, Code of Ethics, ethics controversies, and differentiating consent, permission, and assent, and discuss how promoting the best interest of children. Obtaining informed consent from a competent adult. So let's get started. Care of children and their families requires the application of the nursing process in accordance with accepted standards of practice, performance practice, and ethics. There is a public perception of nursing. So for the 19th year in a row in 2020, so I believe it's like almost 22 years in a row now, nurses are respected respondents for successfully performing an overwhelming job of providing life-saving care during the COVID-19 pandemic. We were placed first in honesty and ethics at 89%. So that it continues to be the public's perception of nursing. And of course, we use the ANA Code of Ethics for nursing. So the Code of Ethics, you know from ethics class about the covenant between a profession and practitioners. The ANA Code of Ethics serves as a code of guidance for empowering individuals and the profession as a whole. The pediatric nursing scope and standards of practice are the primary source of standards for pediatric nursing. It relies around the tenets of therapeutic relationships with families and the patient, also professional boundaries and personal authenticity with our patients. And there are some challenging patient and family behaviors that we deal with. Consider things such as babies that are addicted to drugs, mutual respect and trust, empathy, advocacy, and avoidance of extremes with the relationship continuum from enmeshment to disengagement, result in empowerment of families and children. The therapeutic relationship challenges that we see are abused and neglected children, terminally ill children, addicted to drugs, those with chronically ill conditions that leads to repeat hospital readmissions, streetwise adolescents who challenge everything and everyone, children in families who are perceived as non-compliant or non-adherent, and children who have borderline personalities and other mental illnesses challenge our authority as well. So family-centered care, again, the overview is that we take care of the whole family. So that's therapeutic. There's often a lack of distinction. And practitioners are made to feel warm and fuzzy, that in fact you have to be very therapeutic with some families, which gives you a lack of distinction between a parent substitute and a caring, nurturing professional. Good nursing judgment and prejudice are judgmental. So sometimes the art of nursing really comes into play when we deal with our patient vulnerability. There are lots of rewards in being in therapeutic relationships with families because you're able to see the contributing factors, the things that you do make a large life change for some of these kids. There are other practitioners that are specialized, and those are called child life specialists. Those are also people who work with children to help them get through their illness and the hospitalization. They are using play to help the patient to understand what's going on with them. So the ANA Code of Ethics of Nursing can be characterized as which of the following: a source of guidance and empowerment, a covenant between the profession and the patients we serve, a reflection of key ethic principles, duties, virtues. So D, all of the above. Remembering developmentally appropriate care, so development and pain management along the lifespan. So we do treat infants as having pain because they do. The pain threshold can be very detrimental to brain development. So we do a lot of sucrose and sweeties to reduce pain in infants because we know that that's going to affect them developmentally lifelong. Patient and family education. So a lot of patient and family education, especially teenage parents, you're helping them to develop adult behaviors in caring for their infants. And the privacy and confidentiality that we have to deal with, just a little bit different in the pediatric realm versus the adult realm. So sometimes we'll have conflicting duties being a nurse. So those conflicting duties can be hard, but the most of the time it has a lot to do with like the privacy and things like that. So we want to be maintain dignity for the parents, but we also want to get a child out of a situation that's limiting or legally not efficient for that patient to be in. So even though information may sometimes be withheld from parents, the professional shouldn't lie on behalf of the child. And if you're unable to convince a child to disclose, confidentiality will be disclosed. Chaperones, sometimes we'll have chaperones in care that are someone that can make decisions for them in the meantime. Sometimes during examinations of the breasts and the genital areas, we'll have a chaperone available, only because we never want to be in that situation of he said, she said. If there's an examination of the child or the parent and they seem to be anxious, suspicious, seductive, mentally or cognitively impaired, and in litigious society that we're in today, you can always ask for a chaperone. You never want a medical history with detailing questions about a sensitive nature to be misinterpreted inappropriately. So we always have someone of the opposite sex in the room with the provider at all times. HIPAA, again, HIPAA at change of shift, we just have to be careful. There's usually privacy passwords. So just check with your hospital's situation, but there's usually a password or a number on their band that the parent can give us. We never know the relationship between the two parents. Sometimes it's very strained, so we want to make sure that we're giving the right person the right information. In pediatric decision making, I always have to have the best interests of the child in mind, and sometimes the role of the parental religion will also interfere with medical decisions as well. All we want to do is make authentic attempts to understand the family's wishes and priorities and the values behind them, make any partial accommodations or compromises that we can, and update the parents on the child's condition and keep them involved in ongoing planning of care for the child. So if someone was 15 years old with acute appendicitis who's fearful and resisting surgery, they'll usually be taken to the operating room even against their wishes. because of the best interest of the child. So there's a good figure 2.2 on page 22 in your book, and that kind of tells you how we deal with some of those things. If it would be a reasonable and prudent person would choose to have that surgery versus have their appendix rupture, then we'll go ahead and take them into the OR and get the surgery done. There are some biomedical ethic principles such as autonomy, beneficence, non-maleficence, justice, veracity, fidelity, and the sanctity of life. So those also come into play. So remember to go back over those on page 22 as well. Partner with children in decision making. Usually a child will be able to understand what you're trying to do and try to help them make a decision on their own. Decision making, just make sure that you look on page 23 for consent, assent, and permission. So informed consent is an adult making decision-making capacity. So there are emancipated minors, and mature minor doctrine provides exceptions for kids 18. In parts of Canada, the age for consent is actually 14, and teenage parents may make decisions for their baby that they can't legally make for themselves. So just make sure that you go over that. If a child is pregnant, they are the ones that provide the consent for the child that they are bearing, not their parents. But if they needed to have their appendix out, we'd have to have their parents sign their consent. So, informed parental permission. If it has to do with STDs or sexually transmitted diseases, it is not that you have to have the parents' consent. So the national patient safety goals, again, just with the 2 patient identifiers and the fall reduction. Fall reduction really comes into play with pediatrics because they're tiny people. We've got to make sure that we have all of the information that we need to prevent patient identification issues and patient falls. So we usually use an ID and put it on their foot so that they have a hard time removing it. Teenagers, again, might have their ID removed when their friends are visiting if they're not aware of their hospitalization. If a child's in an outpatient setting, then they should be able to provide us with their name and date of birth without an ID being present. And then when parents are not present and ID has been removed, there has to be another standard way of identifying that child before putting on a fall band or a name band. The fall reduction risks, again, Miami has a fall protocol that's widespread and going to other settings as well. So cribs, high chairs, everything that's not secured needs to be monitored appropriately. Crib railings need to be up at all times. So just being careful with those kind of things in the hospital setting, that's not normal to do normally. There's medication safety standards and safety precautions so that you don't give a med to any child unless it's been double checked. Throughout the country, that's a US thing that we do not give meds on our own. We have to double check all of our meds with another nurse. So imagine being, a very busy NICU and you have to double check everything. So there are computer systems coming out to be able to help us with that. But at this point in time, a lot of hospitals still have the 2-check rule. Children in the US do not have the right to confidentiality until they reach 18. True or false? So false. Children do have the right to confidentiality, although there's certainly a practical consideration to preclude it. Okay, and then advocacy, obviously, we advocate for children that are in maltreatment situations, ethical issues, life-threatening issues, things like working when you're too young. placebos in research, conflicts that arrive in confidentiality requests, informed consent, non-coerced consent, and withholding all treatment options from the child. So there's lots of those that come into our realm. Physical abuse, mental abuse, all those good things. Mental problems, physical abuse, sexual abuse, neglect, poor medical treatment, pediatric condition, falsification. Those are all in your book as well. Just understand the definition of neglect being the failure to provide basic needs for a child, putting them at significant harm. Deficits can be in the areas of food, shelter, clothing, education, healthcare, or safe supervision. So there's quite a few cases coming through right now with those ethical issues. Sometimes people who assume to be nice are not necessarily their parents, so we're definitely double checking IDs and stuff at this point in time, in this day and age. And then just some of the strategies that we use. Advocacy, membership in professional organizations help you with that. Letters to legislators, participation in local initiatives, and community education of welfare, especially hot topics, speaking engagements, and other platforms, especially around human trafficking at this point. So, again, in summary, in this chapter, we covered ethics in nursing practice, the pediatric scope and standards of practice, family-centered care, developmentally appropriate care, some pediatric decision-making, safety in the pediatric setting, standards of practice in culturally sensitive care, truth-telling standards for pediatric nursing, and advocacy.